Okay, hello everybody and welcome. I'm Dr. Natalie Scheeler and I'm joined by Dr. Claudia Bustamante and we are from Foundational Medicine and today we are going to be talking about PCOS and then more specifically PCOS and the microbiome. Before we get started, Dr. Claudia, do you want to kind of introduce yourself? Tell us a little about yourself.
Yeah, so I am a naturopathic doctor and a certified functional medicine provider. I focus on gastrointestinal, women's health, and cardiometabolic conditions. I am also a nutritionist, so nutrition plays a big role in my practice, and it's something that I'm always incorporating with my patients.
Yeah, and so this topic kind of works out perfectly because PCOS will bring in the microbiome and the kind of gastrointestinal component too, but there's also a lot of cardiometabolic and then obviously a women's health topic that we're talking about. So it covers all of your common bases today. And so today, kind of just what we'll do is we're going to start off by going over kind of foundational about PCOS and the basics so everybody's on the same page. And we'll do that in part one. And then in part two, we'll talk about the kind of PCOS and the gut microbiome specifically. So if you feel like you have a strong foundation in PCOS, you're more than welcome to jump ahead to part two when we kind of dive into the nitty-gritty about the gut relationship, microbiome relationship, and PCOS. But if you would like a refresher or to be introduced to some of these, feel free to keep listening. So to start us off on the basics, can you tell us a little bit what is PCOS?
Sure. So PCOS stands for polycystic ovarian syndrome. And it is a condition where many times we see multiple follicles in the ovaries, and it is a hormonal disorder. So we see high levels of androgens, and these are hormones like testosterone, dihydrotestosterone, DHEA, DHEAS, and androstenedione. We also see low levels of hormones that are needed for ovulation, like FSH and progesterone. So women with PCOS many times have anovulatory cycles, which increases their risk of infertility. And this is one of the main complications or one of the main reasons why patients with PCOS seek for medical advice. PCOS is also a metabolic disorder. And in PCOS, we commonly see high levels of insulin. Insulin is needed to allow glucose to get into the cells. But when our pancreas releases high amounts of insulin, it can't work properly. And patients can develop a condition called insulin resistance. Insulin can increase levels of androgens and can increase levels of inflammation. High levels of insulin increases the risk of cardiometabolic conditions like diabetes, hypertension, sleep apnea. But also we know that higher levels of inflammation can really impact how we feel. So psychological disorders like depression and anxiety, eating disorders are also more prevalent in patients with PCOS.
So we kind of flirted with this, but how common do we see PCOS? Is it something that is common in women? Tell me a little bit about that.
Yeah, it is estimated that about 10% of females have PCOS.
Mhm.
But that being said, it's commonly underdiagnosed.
Mhm.
Yeah, it's estimated that about 50% of cases remain underdiagnosed. And interestingly, one study found that over one third of PCOS patients, for them, it took over 2 years to get a diagnosis.
Mm.
And most of them had to see three or more healthcare providers in order to receive a diagnosis.
Why do you think that is? Why do you think it is so underdiagnosed?
Yeah, so it can be related with milder symptoms, like difficulty losing weight or weight gain or irregular menstrual cycles. Many times we normalize some of these symptoms and we don't seek for help or for care until women cannot get pregnant, for example. That
Mhm.
is one of the complications. Also,
Mhm.
the presentations of PCOS vary a lot among women with PCOS, and that makes the diagnosis less straightforward.
Mhm.
Yeah.
Yeah, okay. And so I kind of what we mentioned earlier, for some it can look very classic picture, which we'll talk about PCOS
Mhm.
wise, and then some it can not really even be super prominent until they are trying to conceive and then are not able to
Totally.
without.
Yeah. Classic symptoms can be like excessive facial hair growth, also known as hirsutism,
Mhm.
but not everybody presents with that classic picture of
Yeah.
PCOS.
Hmm.
Mhm.
Okay. And before we kind of get into a little more into the diagnosis and what that looks like, can we talk a little bit about what actually is happening in PCOS? And I do have a picture a diagram that will, I think, be supportive of your explanation here that we pull up.
Great.
Um,
Okay, so this is a great graph to understand the connection between the brain and the ovaries. In the brain, specifically in the hypothalamus, we produce a hormone called GnRH. And GnRH can stimulate the anterior pituitary, also in the brain, to produce LH and FSH. And these hormones are going to travel to the ovaries to produce sex hormones like estrogen, progesterone, testosterone, and to stimulate ovulation and the release of an egg each month. So this connection between the hypothalamus, the pituitary, and the ovaries is what we know as the HPO axis. And in PCOS, this connection is dysregulated. In PCOS patients, the hypothalamus produces GnRH, and these GnRH pulses are very fast. So when GnRH goes to the anterior pituitary, it produces more LH. So a lot of LH and little FSH are gonna stimulate production of, mainly LH is gonna stimulate the production of androgens in the ovaries, like testosterone. And also the HEA is produced as well, can be produced in the ovaries. And when we have high levels of androgens and low levels of FSH, what is going to happen in the ovaries is that the follicles cannot fully mature. So there is not going to be a dominant follicle to release an egg and to have an ovulation. We need FSH for maturation of the follicles. And when we don't have that, we commonly see in patients with PCOS multiple small follicles in the ovaries. There's no dominant follicle, so there's no ovulation. And when there's no ovulation, we tend to see low levels of progesterone because progesterone raises after ovulation. We commonly see unopposed estrogen to progesterone. So there is higher levels of estradiol or estrogen in comparison to progesterone. And that unopposed levels of estradiol to progesterone can cause a condition called like endometrial hyperplasia, which increases your risk of endometrial cancer. And that is one of the main complications that can happen in patients with PCOS. Progesterone is also needed to send a negative feedback to the hypothalamus to slow down those GnRH pulses that, when they're too fast, they produce more LH than FSH. So we need that negative feedback of high levels of progesterone to the hypothalamus to slow down the brain and produce normal amounts of LH and FSH. But in patients with PCOS, this connection of the ovaries and the brain is disrupted. So we commonly see high levels of androgens, low levels of progesterone, unopposed estradiol to progesterone. And we also commonly see that because there's no ovulation, we have small follicles in the ovaries. That's very common. When we do, for example, a transvaginal ultrasound, it is a common feature seen in patients with PCOS.
So with PCOS, that communication, the GnRH pulses faster, leads to the increased LH, and then downstream we see more production of the androgens, including testosterone. You had mentioned insulin earlier. When does insulin come into this
Mhm.
equation?
Yeah, insulin can also stimulate the ovaries directly to
Hmm.
produce more testosterone, which is very interesting. It can also increase these pulses of GnRH to send that signal to the ovaries to produce more androgens. So, yeah, it can act like send that signal to the brain, but also stimulate, it can stimulate the ovaries directly.
Yeah. And which very interesting. One of the other things I see kind of popular on social media around the PCOS conversation is a lot of conversation around stress. How does stress play a role in this cycle?
Stress can also stimulate the adrenals to produce androgens like DHEAS. So DHEAS is mainly produced by the adrenal glands. Not only
Mm,
the ovaries produce androgens, but also the adrenals. They can also produce testosterone and mainly DHEAS. So when we see elevated levels of DHEAS, we know it can be related to the adrenals, and some physicians name this as adrenal PCOS.
mhm. Okay. Okay. And so how do we, as practitioners, how is the diagnosis of PCOS actually made?
The diagnosis of PCOS can be done using the Rotterdam criteria. And for this criteria, to meet the criteria, you need to have two out of three features. Number one, having irregular or absent menstrual cycles. Number two, having clinical hyperandrogenism, and this means clinical signs of having high androgens. Like having excessive facial hair growth is a classic symptom of PCOS. Having
Mhm.
acne as well. So it can be that, or having high levels of androgens in a serum test.
Mhm.
So you
So
don't
number
have
two can be either, sorry, didn't mean to interrupt.
either
It
or.
can either the clinical signs, which you said the m- uh, facial hair growth, hirsutism, acne, and sometimes hair loss too on that one,
Yeah,
or the biochemical, which we is seeing these high levels of androgens in the blood, and that's all under number two.
exactly.
Great. And then three.
And number three is having PCOS morphology as seen on a transvaginal ultrasound. And this means having more than 20 follicles per ovary that measure between 2 or 9 millimeters, or having an increased ovarian volume.
Okay. And as a provider, I sometimes using a transvaginal ultrasound for this diagnosis and screening is a very helpful tool, but it's not always the right tool to use depending on the patient because if somebody's very young and hasn't had penetrative sex, that can be a really um, challenging exam. Are there alternatives to using the transvaginal ultrasound for diagnosis?
Yeah, so some studies suggest that high AMH levels can be used in place of a transvaginal ultrasound, as higher levels of AMH strongly correlates with ultrasound findings in patients with PCOS.
Okay.
So those patients that have higher levels of AMH usually have a higher follicular count as
Okay.
seen on a transvaginal ultrasound.
And for those who don't know, do you mind just explaining what AMH is?
Yeah, it means anti-Mullerian hormone, and it can give you an idea of follicular count
Okay.
in females. Yeah.
Hmm. Okay. So that could be using the AMH if the transvaginal ultrasound does not make sense for the specific patient, could be a potential option to consider. It's not a definitive diagnostic criteria that has been widely accepted, but it's something that could be considered if
Yeah, it is
depending on the
something
patient.
that supports the diagnosis.
And then
So,
obviously too, you mentioned we only need two of three of this to make the diagnosis. So if a patient meets the first two criteria, meaning
yeah.
having the irregular or absent menstrual periods or the clinical or biochemical, markers of hyperandrogenism, they also would be able to meet that diagnosis without the ultrasound.
Totally. Yeah, AMH is supportive of the
Mhm.
diagnosis, but it has not been fully recognized as a tool to diagnose PCOS. Yeah,
Got
it
it.
is also important to note that in women that have obesity, this
Mhm.
may not be an accurate marker.
Okay. Okay. And so that is how we use the Rotterdam criteria to make the diagnosis. But as a naturopathic doctor, we kind of treat the whole person. We like to look at the root cause. And so in your workup with somebody you're either suspicious of PCOS or even have diagnosed with PCOS and you want to monitor or kind of look a little bit deeper, what type of labs are you typically considering?
Yeah, so let's just start with hormone testing.
Great.
I usually run most of these labs on day 2 of the menstrual cycle, like FSH, LH.
And just sorry, before you go too far, day two, for those who don't know, so day one being the first day of bleeding in a cycle, and then
Exactly.
day two, second. Okay, sorry,
Mhm.
resume.
Yeah, you're good. So on day 2, we measure FSH, LH. Remember that these hormones come from the anterior pituitary and send signals to the ovaries to produce hormones like estrogen, androgens, and we also talk about progesterone. So I
Mhm,
also like measuring estradiol, AMH, or anti-Mullerian hormone. 17-hydroxyprogesterone, and this is to rule out other possible causes of having signs or symptoms of PCOS, like congenital adrenal hyperplasia.
mhm,
So when I'm ordering labs for patients with PCOS, I'm also ruling out other conditions
mhm,
because there are other conditions that can present or manifest like PCOS. So I
mhm,
will order this test also on day 2. And then if I have patients doing labs, I will order other labs that don't have to be done necessarily on day 2, but I will also get testosterone, free testosterone, DHT or dihydrotestosterone, which is a very potent form of like a very potent androgen. I will also order DHEAS. We talked about this one being produced mainly in the adrenals, so it can help us know where are androgens coming from. Are they coming from the adrenals? Are they coming from the ovaries? Yeah,
mhm,
so not only the ovaries produce DHEA, the HEAS is mainly produced by the adrenals. Androsteronidione is another one that I order. It's a weaker form of androgen, but it can be converted into testosterone in the adipose tissue.
mhm,
I will also order sex hormone binding globulin because when this one is low, we have more free testosterone. This hormone binds to free testosterone. So we want this hormone to be higher to bind to testosterone and not having too much free testosterone circulating.
mhm,
Yeah, and then we have progesterone, and this hormone is best to test on days 5 to 7 after ovulation. If somebody is having regular menstrual cycles, but we know that patients with PCOS don't always have regular menstrual cycles, you can use ovulation predictor kits to measure progesterone rise, and then you will do the blood test about 5 to 7 days later to check for progesterone levels.
mhm. And it's also possible that somebody with PCOS isn't ovulating at all, and so that's just you. I have patients who check, and they don't ever
Yeah.
get that surge, or sometimes it could be a false sense, and so um, I guess per patient, you tailored to as far as
Mhm.
progesterone timing. Okay.
Yeah, as we said, that's the hard part with PCOS, that it doesn't manifest equally between patients with PCOS. Somebody can
Hmm.
have like regular menstrual cycles and have PCOS,
Hmm.
and somebody can not be ovulating at all. And
Hmm.
that's like more classic in PCOS.
Yeah, and so that's the hormone side of things, and the sense I'm getting, and we'll talk about this when we get a little bit more treatment, is that because PCOS itself is heterogeneous, meaning different presentations of it. Looking a little bit closely at these different hormones like the DHES versus testosterone kinds of gives us a better idea of what maybe treatment interventions might be more beneficial for somebody. Is that why you're looking at these or?
Yes, exactly. But
Mhm,
also there are other labs that I always run in my patients with PCOS, mainly
mhm.
because they are at higher risk of different cardiometabolic complications.
Okay.
So I do like to assess for insulin resistance. Many times I will order fasting glucose, fasting insulin, hemoglobin A1C. The best test to assess for insulin resistance is the 2-hour glucose insulin tolerance test.
Hmm.
So if patients are willing to do this test, I will order.
What does that look like for people who may not know?
Yeah, it is a test where you have to drink a solution that has glucose,
Hmm.
and then they're measuring your levels of glucose and insulin during 2 hours.
Hmm.
And what they want to know is how much insulin and like how much it peaks
Hmm.
during that time period. Mhm.
Okay. Okay.
Yeah.
Um, and then so you're looking at the blood sugar side of things. What other cardiometabolic labs are you like to look at?
Yeah, and that being said, there is also a formula called HOMA-IR
Hmm.
that you can calculate with a fasting glucose and fasting insulin and can give you a good idea if there is insulin resistance.
Yeah. I
Yeah,
like
but
to use that commonly too. Hmm.
yeah, then I also like looking into a lipid panel because women with PCOS tend to have higher levels of lipids.
Hmm.
And depending on the case, I will order more advanced cardiovascular testing if I think
Okay.
it's needed. Hmm.
Okay. Then as far as any other labs that you like to look at?
Yeah, I also like to look at vitamin D because we know that vitamin D plays a role in improving insulin sensitivity, and deficiency of vitamin D is very common among women with PCOS. Sometimes I will also order leptin. Leptin is a hormone made by fat cells that tells your brain when you're full and you have enough energy so you can stop eating. When
Hmm.
your body stops responding to leptin, you can have something called leptin resistance,
Hmm.
and you may feel hungrier. And weight gain is very common among patients with leptin resistance. So that is something to consider. There's some interesting research suggesting that high levels of leptin can disrupt that GnRH pulse from the brain that sends
Hmm.
signals to the ovaries. Well, first to the anterior pituitary to produce more LH, FSH, but if it disrupts that pulse, we will have higher levels of LH over FSH, and that can increase androgen production in the ovaries.
Mm. So it seems like it goes pretty hand in hand too with the insulin resistance and pushing those androgen pathways.
Yes, totally,
Mhm,
totally. Yeah, other labs that
mhm,
we can assess in patients with PCOS are a complete thyroid panel, and this is because having hypothyroidism, for example, can cause absent of menstruation or
mhm,
irregular menstrual cycles. So something to
mhm,
rule out. Let's remember that PCOS is a diagnosis of exclusion, so we need to
mhm,
exclude different conditions. Same as prolactin, it can be mildly high in patients that have high levels of stress or hypothyroidism, but when it's very high, we should suspect a tumor in the pituitary gland. That can also mess up with ovulation and cause irregular menstruation. So
mhm.
definitely something to rule out and to look for.
Okay. And so just to summarize the lab portion, so we have our hormonal labs, which I won't rename because there's quite a bit, but we have our hormone lab bucket, and then we have our cardiometabolic bucket. We're looking at blood sugar and lipids, leptin, kind of have our miscellaneous with vitamin D, and then making sure that we're covered, that we've ruled out any other conditions that could also present similarly as PCOS.
Exactly. Yeah.
Okay.
Yeah.
Okay. Okay, great. I think that covers our foundation. Do you have anything else you want to add before we move into part two, talking more about the microbiome?
I think we're ready.
Okay, great. Well, if you're interested in part two, jump to the next video and we'll break down PCOS and the microbiome.